Well, then I'll start with the anatomy of obstructive sleep apnea. And yeah, I got to figure out how to do this. So I was tasked by the American Academy of Sleep Medicine to provide a lecture on normal upper airway anatomy. And I really, when I went there, I changed it to anatomy of obstructive sleep apnea, because you look at normal anatomy, okay, this page out of one of your anatomy books, it's boring, okay, but nobody looks like that. So the anatomy of obstructive sleep apnea is basically obstruction or anatomy of the upper airway, which of course begins at the nose and includes the mouth, oral airway, and then the pharyngeal airway, which is broken down between nasopharynx, oropharynx, hypopharynx, and even the larynx. And why is anatomy important? Treatment choices in 1986, when I was a senior resident, includes CPAP, which had just become a commercial device that year. CPAP was basically invented or discovered in 1981, but it became commercial in 1986. And then the only operation we had was the UPPP. And this is the original method developed by Fujita, which nobody should do anymore. But that's what we had in 1986. And so why is anatomy important? Well, because if all you have is a hammer, then everything looks like a nail. All we had was the UPPP and everybody got it. And I don't know if anybody's familiar with Aaron Scher's paper, 1996, which was a meta-analysis that looked at all UPPP surgery papers up to that time, and came to the conclusion that for all comers, there was about a 40% success rate or 41% success rate. And if you tried to discern who was going to respond by having the patient sit in the chair and doing an exam, you could get it up to maybe 50%, but that was it at the time. And anatomy is important because it impacts treatment. One procedure does not fit all cases. So how does upper airway anatomy impact the treatment options for obstructive sleep apnea? These are our options: positive airway pressure, oral devices, positional therapy, weight loss, medications, more important in children, didgeridoo, believe it or not, British Medical Journal, and then surgical intervention. So upper airway anatomy is complicated because who's to say what's normal versus what's abnormal? Sometimes things are obvious, but many times not very obvious. And then there's the interplay between multiple obstructive sites. And question of tissue compliance or stiffness varies between individuals. And this is a measure of critical closing pressure. Why some people will obstruct with a lesser negative pressure, and for others it takes a higher negative pressure. Glossoptosis, means the tongue falls back, happens in adults as well as young kids. And the question of muscle tone, too. As the years go by, we don't have the muscle tone we did when we were in our 20s. And then we need to talk about the interface of anatomy and physiology. You have the container, the facial skeleton basically, and the contents, soft tissues that fill up that facial skeleton. There's tissue compliance and muscle tone. And there's also, what I haven't listed here, is the negative pressure reflex. When there's a negative pressure in the pharynx, it sends a signal to the muscles to tighten up and keep the airway open. But the intensity of that reflex varies between individuals. So it's a little bit more than just anatomy. So how should we, as otolaryngologists, evaluate these patients with obstructive sleep apnea? We have to keep in mind that there's an interaction between anatomy and treatment. So the next section is, how does exam direct procedure selection? This was what Adrian was asking about earlier. So the basic concept, this is an anatomic disease, although there's some interplay of physiology. We must identify these anatomic abnormalities the best we can, and our goal is to make the airway bigger and more stable, including the nasal surgery, the retropalatal, retrolingual, and hypoglossal nerve stimulation implant. which actually is physiology overcoming anatomy in that last one. So success of surgery depends on our knowledge of anatomy, and we must consider the functional aspects of obstruction because the airway awake is not the same as the airway asleep. And then there are multiple levels of obstruction. And this is the case probably in 75% of patients. And we have to realize this because modifying any one structure, as in the shear paper I mentioned a moment ago, is generally insufficient. Although there's some patients will resolve with one procedure, but you can't tell them that. You need to identify the primary sites of obstruction. What's most obvious to you? And identify secondary sites of obstruction, which you generally don't see very easily until after you treat the primary sites and get them out of the way in order to make things clear. And then you stage surgery. This is the way I would do it. Initially, Stanford University in California talked about phased surgery, where phase 1 was to take care of everything in the airway at once, whether it was a highway, genioglossus, palate, whatever, to do it all in one setting. It's a very morbid way to do things, but that was early on. That was back in the 90s. And you risked taking care of structures that maybe would not need surgery had you done it in a staged fashion. That's my take on things. So you do the primary obstruction first, and this uncovers secondary sites. Or, I'll give you one example. There was an attorney I took care of probably about 10, 12 years ago who had multi-level obstruction on my exam. He was a mouth breather, he had turbinate and septal deviation, turbinate hypertrophy and septal deviation. His palate and tonsils looked obstructing, and also the base of the tongue as viewed with endoscopy. So I told him, let's take care of the nose first, because at that time I was going from the nose on down as my progression. So I took care of his nose. He improved significantly. He thought he was cured. I've got his AHI down from 44 to 26. And I said, no, we got to do the palate, and I think after that we're going to have to take care of the tongue base. So we did the tonsil with UPPP, and he thought he was cured again, so we did a post-op study, and he was cured. So I didn't have to do the tongue. But if I did everything at once, he would have had unnecessary surgery. And that's an illustration of why I like to stage things. So when the patient walks in your clinic, sitting in the chair, think to yourself, why does this patient have obstructive sleep apnea? Now, Kenny Pang from Hong Kong gave a very great presentation on this. He talked about the global versus local classification of obstruction. Global, you're talking about weight and adipose deposits. In the local classification, you're looking at anatomic abnormalities. And then he says, look at the container versus the contents, the bony skeleton and the soft tissues, because the best you can be is with the bony contents. And if that's limited, then that's going to limit your volume, airway volume. And then you look at the sites, which we just talked about. So anatomy is revealed by upper airway evaluation, of course. So we begin with these exams with the patient in the chair. Probably takes about 5 minutes to do a good clinical exam of the airway. But remember, the airway is not static, but it's dynamic. And I use this example. You have two kids with same size tonsils. And I had this. They're sitting in one room and the other kid in the other room. The kids look the same. One has obstructive sleep apnea and the other one does not. So it's a dynamic airway. It's not a static airway. So airway evaluation exam, which we just talked about. Imaging can be involved, although it's not primary, and then endoscopy. So BMI and neck circumference. Neck circumference probably more important. And in the male, you're looking at 17-inch neck, and in the female, 15-inch neck. Then look at the cranial structures, we'll talk about in a moment, and then the airway soft tissues, which you're very good at. And understand that 75% of these OSA patients will have a disproportionate anatomy, skeletal deficiency, which could be just very minor and not standing out, but you learn to pick up on these. So you saw this slide in the last time that we talked. BMI is a major player, and we know that 70% of obstructive sleep apnea patients are obese, but that also means that 30% of our patients are relatively normal weight. And then 40% of obese patients have obstructive sleep apnea. But on the corollary to that is that 60% of obese patients do not. So why is all of this happening? So we know obesity is a contributor or even a cause of sleep apnea because you have both extrinsic airway compression and then you have intramuscular fat in the tongue as well. Sometimes the palate will build up fat also. But then again, BMI is not a great standard for obstructive sleep apnea. It's the neck fat that's most important. And I think we had this slide last time too, that weight loss can improve OSA, not in everybody, but it is modest in the improvement. And then in bariatric surgery, you see a mega obese BMI 55 coming down to severe obesity at 37, and they get improvement with their AHI, but they're still in moderate, low moderate severity in this meta-analysis. So I love this slide. Nashi looked at 121 patients' autopsy. Their manner of death was varied and not related to sleep apnea, but he looked at fat tongue deposit. There are 3 zones of fat deposition, and it was the posterior zone that put on fat the quickest as people gain weight. And I guess another way to think about it is some people may put fat on in their gut, some will put it on in their thighs, other in their butt, some in their neck, and some in their tongue. So looking at the percent fat versus BMI, you can see the red line is the posterior tongue, and the black at the bottom is the anterior tongue. So looking over to the right, you see the BMI of 50, and you go up on the red line, and the fat in the tongue is like 50% of the tongue is fat in that particular individual. So that's one of the reasons that some obese patients will get obstructive sleep apnea. And again, Richard Schwab, he did some really great studies in the 1960s, University of Pennsylvania, or 1990s. And he did imaging, and you can see the difference between the normal patient and the obstructive sleep apnea patient as far as airway and fat white, airway black, but you know that. So this shows some fat deposits in the tongue and the submental fat, but you also see that the palate is longer and the airways are narrower, both retropalatal and retrolingual. And another one of his publications shows that the normal airway on the left at end expiration versus the OSA airway on the right. So end expiration is during awake is the most minimal muscle tone of the airway. And during sleep, that's when the obstructions actually would occur as you're trying to inhale against this closed airway. So I thought this was a pretty remarkable slide. And then the lateral pharyngeal wall, you can see the fat pads in white, not a whole lot different, but there's a lot of tissue, and what happens, CPAP presses laterally. So that's how CPAP works. It expands the airway in a lateral dimension. It does not push the tongue forward. It does not compress the tonsils. And one of the reasons of CPAP failure is the tongue is so big, it cannot open the CPAP cannot open the airway. Now, sometimes it's the epiglottis that's a problem, and CPAP actually worsens epiglottic obstruction. And so they get up to CPAP pressures of 24, and they're still failing. Not real common, but you do see those. And now weight loss, it thins the airway, and you can see in this patient how 17% weight loss actually opened the airway. And I think these are remarkable anatomic slides. Now, as far as risk groups for obstructive sleep apnea, there's one group where it's virtually impossible to get obstructive sleep apnea. We talked about that 60% of obese patients who just don't get it. And then one is predisposed to get obstructive sleep apnea even with a normal BMI. And these folks may have the facial skeleton, as we see just below. It says abnormal cephalometrics. And then one gets obstructive sleep apnea with weight gain. I had a patient that I remember very distinctly. When he would go over 180 pounds, he would begin to snore. His wife would tell him he'd start to lose weight again. And for them, that worked pretty good. But the obstructive sleep apnea patients, once you have obstructive sleep apnea, there's three groups. There's the abnormal cephalometrics or facial skeleton, and then morbid obesity or both. So cephalometrics, that's something that we don't hear about very much anymore. It's used primarily in dental and oral surgery, but early on, it was used in looking at sleep apnea, and I actually used it in private practice. So it's the X-rays taken 6 feet away, and it's a very defined way of doing it. It's not just a lateral skull film. And what we see written up there on the right are various lines, and they have some meaning. And usually people with a normal BMI and obstructive sleep apnea have an abnormal cephalogram. And if they have a high HI, probably have an abnormal ceph. Now, medical insurance does not cover this. I had worked out a deal with one of my local dentists when I was in private practice where he would charge $50 for a ceph. And I would actually do these measurements and have them in the file before we went to computer. And so, again, one group is predisposed to get obstructive sleep apnea. Smaller retromaxillary airspace can have multiple craniofacial abnormalities. Dr. Carr sees these with the young kids. And then facial skeleton is smaller relative to the middle cranial fossa. Again, BMI is not the great standard because if there's no craniofacial load, they have to get really obese to get sleep apnea. And again, stressing the amount of fat in the neck is most important. And you'll see a lot of these folks with very short necks or necks you can't palpate much through. They'll have longer, fatter palates and bigger tongues, which we mentioned. Okay. In the clinic, sitting in the chair, this is what you might see. Either have a retrusive mandible or a deficient midface. And these are things that I mark down if they have a retrusive mandible. You don't see many folks, I don't see many folks with the deficient midface. And one reason I don't like to provide CPAP to kids if TNA fails is because you have that pressure on your face for 10 hours a night, and it can actually impress the midface. There's a couple studies out of oral surgery showing that. And in kids like maybe the trisomies, it can make their sleep apnea worse over time if it compresses the midface. Okay, so these are angles that we look at. The sella to the nasion, to the anterior maxilla, or to the mentum. And so SNA and SNB angles are probably the most predictive looking at retroposition mandible or retrusive maxilla. Let's see. I keep moving my slider so it doesn't change it here. So I have looked at space at the tongue base. The PAS is posterior airway space. If it's less than 6 millimeters, that's pretty significant. And you'd look at a hyoid suspension for that if we were still doing this. And then the MPH, that's the mandibular plane to hyoid. It's supposed to be a right angle there. But if there's a high mandibular plane to hyoid greater than 22 millimeters, they don't do well with the UPPP. So these were out of some of the early studies to look for when UPPP will work, because that was the majority operation. So let's talk a little bit more about exam. Okay, we know BMI greater than 30, male 17, female 14. I think I said 15 inches earlier because different papers will say different things. So my internal medicine colleagues, I tell them, okay, you don't have to do the exam that I do, but do they have a large tongue? You can mark that down. Do they have tonsils taking up more than half the airway? Is the uvula large? Are they mouth breathing? Do they have a retrusive jaw? That's a very basic airway evaluation. But this is an evaluation that we do, and I think I mentioned this last time with Terrence Davidson's Sleep for Surgeons. It's very great, and this is something you can maybe keep in your hip pocket when you're looking at OSA patients, and you mark different categories of obstruction through the airway. For the nose, okay, we know there's all these structures we can deal with, and subdeviation. And this is very normal to you. You look at these all the time, but the internists and family practice doctors don't. And so, are they mouth breathing? I think that's the biggest thing you got to remember. If they're mouth breathing, nasal surgery will probably work. I haven't gotten my paper out yet, but I'm working on it. So one of the other problems with nasal obstruction is that it can interfere with CPAP use. Increased nasal resistance predicts poor compliance. And in private practice, I used to measure a resistance, but after a short time, insurance didn't cover that. So I was just doing it gratis because that was part of my approach. Mouth breathing during sleep, that predicts poor compliance. And nasal surgery has been shown actually to improve use of CPAP, compliance, and it also decreases treatment pressures. And high pressures sometimes make it difficult to use CPAP. Looking at the oral exam, okay, we'll talk about the tongue in a moment, but lateral pharyngeal band, that's a vertical muscle, sometimes part of the palatopharyngeus. And when I've done lateral expansion sphincteroplasty, triple Ps, that actually tends to disappear. Big uvula, like the one on the right, should be reduced. Kenny Pang says he takes the uvula every case, and as I might have mentioned earlier, I'll make it smaller down to what I would try to estimate to be a normal size uvula. But generally, the uvula does not add much to the severity of obstructive sleep apnea. You'll see the wide pillars on both the photograph and the diagram. I think that is very contributory to retropalatal obstruction. And so I will reposition them in a variety of ways in order to eliminate that. And of course, large tonsil, you know about that. So these 4 photos I took, I didn't take the Maori Aborigine in the upper right, but this is to indicate or demonstrate the level of tongue obstruction. Level 1, this is a modified Mallampati. Mallampati was an anesthesiologist in the early 80s who came up with a system to anticipate difficulty of intubation. He did it with the tongue sticking out. Friedman in 2002 or thereabouts decided to modify the Mallampati and have the patient open their mouth 4 or 5 times and try to get a sense of where does that tongue sit. Now, it's not 100%er, but you can get an idea. Friedman tongue position 1, as it's called now, in picture upper left, you can see the pharynx. In Friedman tongue position 2, you can see the uvula or uvula base, but not much else. And Friedman 3, lower left, soft palate only. Friedman position 4, only the hard palate can be seen. And so we're talking about macroglossia or enlarged tongue. And when you're putting this as a diagnosis for an adult, you should put macroglossia acquired. In our system of EPIC, when you listed macroglossia, it would print out congenital macroglossia, so I had to have them put that in. But the tongue fills the oral cavity. And again, there's illustration on the right of Friedman tongue position, but you'll see many times the tongue is indented by the teeth because it doesn't fit inside the jaw. So is it the jaw is too small, or is it the tongue is too large for the jaw? Now, we got to look at the soft palate also, and Tucker Woodson's done a lot of work in this. He's in Minneapolis. And so we know what the visualization of the palate is according to tongue position, but then Woodson talks about the depth behind the soft palate. Is the soft palate smack up against the posterior pharyngeal wall while they're awake, or is there a good airway space? And then looking at the palatopharyngeus, which becomes the posterior pillar, sometimes it's very prominent and other times not so much. And then the hard palate. And he looks at this from an endoscopic viewpoint, where does the hard palate end? Where does the soft palate begin? And then how much is actually hanging down? Because that'll drive which procedure you might choose. So Friedman tongue position, and again, is it a large tongue or is it a small jaw? And then the tongue base correlates with BMI. You look at the vallecula. Is it patent? Is it decreased? Is it full of either tongue or lingual tonsil or both? And then lingual tonsils, I make a note as to whether they're really exuberant, just filling up the retrolingual airspace. Are they bilobed? Sometimes they are. And 20 years ago, when I started doing lingual tonsillectomies with cautery, I would grab one lobe and cut it from the back of the tongue endoscopically. And then when the coblation came out, and I was a little skeptical, I said to the rep, I said, okay, I'll do the next 10 patients, one side coblation, one side with electrocautery. After 6 patients, they were all telling me, this side hurt and this side doesn't. I was convinced that coblation was the way to go. But I think it's still not listed from the manufacturer as an indication for treatment, but everybody uses it. Then epiglottis, is it set back? Is it upright? Is it just leaning against the posterior wall when the patient is sitting? The arytenoids, are they edematous? And do they participate maybe in the obstructive sleep apnea? So some people came up with anatomic classifications. Fujita was the first one in the early 80s to do this. Katsatonis had a great diagram, so I used it. He was one of the ones that initially put out the hands-on sleep apnea surgical course was in the Midwest. I was there twice. Now I'm blocking on it. But Friedman characterized the palate and tongue as either isolated obstruction, combined obstruction, and then Katsatonis put in that supraglottic can sometimes obstruct from the epiglottis itself. But what he tried to do, what Fujita tried to do, was decide in which one the UPPP would work. So the one on the left, palate obstruction, he thought it would work the best. And then when Aaron Shearer in 1996 did a meta-analysis, he said you only got a 50% cure rate if you chose the palate obstruction. And this is clinical exam. They're sitting in a chair, and this is your estimation. So we don't use it anymore. Again, success in 41. And if it was a tongue-based obstruction, 5.2% were successful. And currently, it's pretty close. Friedman, again, looked at tonsil size and tongue position, grading the tonsils 1 to 4, 1 plus to 4 plus, and then the Friedman tongue position 1 to 4. And so he staged it. BMI less than 40. He classified stage 4 as BMI greater than 40. So if you have big tonsils and small tongue, UPPP success 80%. Stage 3, big tongue, small tonsils, 8%. So not too different than Shearer's 1996 paper. So Moore was an oral surgeon, and he tried to classify obstruction at the tongue base with the upper tongue base, upper tongue base and epiglottis, upper tongue base, lower tongue base and epiglottis, and isolated epiglottic. I'm not so sure how the classification really impacts, although we do look at how the tongue obstructs. Now, another way to look at the airway, again, endoscopy. And initially it's performed upright and supine. Sometimes everything is obstructed upright that you don't need to do supine, but the airway is considerably smaller when the OSA patient is in a supine position, in contrast with normals. But this is not always the case. I may have mentioned that my first sleep endoscopy 10 or 12 years ago was with a guy with severe sleep apnea. I think it was in the 30s. I was in the 30s. And I didn't see any obstruction on clinical exam. I scoped him. I put him in supine position. I couldn't find any suggestion of obstruction. When I finally did drug-induced sleep endoscopy, it was the palate, and we took care of the palate, and he was cured. And then passive endoscopy, looking at end expiration when muscle tone is the least, and then active endoscopy, which I've stopped doing more recently, but it's called the Mueller's maneuver. And everybody knows what the Valsalva is. You hold your nose to pop your ears. The Mueller's is the opposite. You hold the nose and you suck in. And this is supposed to measure airway collapsibility. And when you look at the fiber optic airway, try to gauge what you're seeing. Is it normal and widely patent? Is it decreased? Is it very small? Is it totally collapsed? Some people, you will see the palate is just totally obstructing, like in the bottom right when they are lying down. And again, we're going back to Woodson. Looking at the palate from above, it can drop off like a waterfall, and you have a slit-like opening right to left, or at the extreme opposite, you can have an oblique or a circular palatal shape. It's funnel-shaped. It goes down like a funnel. And he divided it from 3 anatomic points: hard palate, the genu, which he calls the knee, which is the intermediate portion of the palate, and then the velum. And so the photos are mine, but the diagram is from his paper. And the vertical, it's kind of a steep drop-off, and you can see it's slit-like. A transpalatal advancement will help that patient more than a UPPP. And then the intermediate, which we call gradual slope, you're narrow at the palate and in the intermediate section. Over on the right, you're narrow in every segment, and so you have that circular or funnel position. That's where I would do the lateral expansion technique for a UPPP. Now, this is a diagram from Tucker Woodson talking about transpalatal advancement. And if you have a palate that drops straight down, shortening it with a traditional UPPP is going to leave the patient with persistent obstructive sleep apnea. And so what you would see on the bottom picture is the oblique, and that's where UPPP would probably work of one manner or another. So distal narrowing, you can do conventional UPPP, or what I do is I choose the lateral expansion technique of UPPP to treat that. And if it's a vertical palate, then a transpalatal advancement. And sometimes I've not been so bold as to do conventional UPPP. I have done a variant, a uvulopalatal flap, where it can actually tuck up the uvula anteriorly and pull it away from the posterior wall. You can easily undo that within about 2 weeks by just cutting the stitches. And the transpalatal advancement is technically a reversible procedure. Okay, and this is just to illustrate how it should work. You elevate a hard palate flap back past the hard palate into the soft palate aponeurosis, resect probably about 5 to 8 millimeters of bone. You put a drill hole in at 45 degrees, pass some suture through the palate, and pull it forward. Actually, it doesn't have that much pain for most patients, and they notice improvement in nasal airway as well. And it's rare. I can't say that I have to this point, and I've been doing this for 20-something years. I haven't seen anybody with velopharyngeal or nasopharyngeal incompetence. I did have one lady of French descent who said she had trouble pronouncing her French words for about 3 months, but that resolved. Okay, what about tongue obstruction? Macroglossia, again, you see that tongue just fill in the oral cavity. But is it a hypotonic tongue, or is it retrodisplaced? I mean, does it lose tone when they're asleep, or is it just big to begin with and there's no airway? A little harder thing to know. So this tongue may not look enlarged sitting up, but then in the clinic, you can put them in a supine position and the tongue falls back. How about that? You need to look for that because that'll guide you on maybe what procedure that you should use. So this is a tongue suspension procedure, and let's see if I need to start it. There it goes. It's about a 1-minute video. This is from the group that makes the siesta airlift procedure, and make a submental incision, and then one screw goes in, a tongue suspension suture goes to the back, and what you're trying not to do is pull the tongue forward. This is illustrating that you're putting the tongue back into its anatomic position as if they were upright. I did one of these last week in conjunction with a hyoid suspension, but using only one suture. I've only done it a couple times using 2 sutures, but one generally is all that you need. And this is a slide I just actually added this morning, where this is drug-induced sleep endoscopy, but this is before that, and the patient is awake. Notice where the tongue is, the vallecula. Okay, now he's sleeping, but his mouth opened when he was asleep. He's sleeping with his mouth open. He's lost the airway. CPAP didn't work with him because he can't push the tongue forward. So what I'm going to do is I'm just going to push on his chin and close the mouth. I'm not going to lift his head or do jaw thrust. I just close the mouth. And now he opens again. So we're going to let the mouth open, and you're going to see him collapse with the tongue falling back. And probably in 50% of these folks, with the mouth open, the tongue falls back. So one of the suggestions I had for him was to use a chin strap without CPAP, and the other suggestion was an oral appliance in order to keep the mouth closed and hold the jaw forward. So right now he's in the process of being evaluated for an oral appliance as therapy. And now this is tongue base reduction by the radiofrequency procedure. I've been doing this since the late 90s also. The original papers out of Stanford showed that there was probably about a 17% reduction in the tongue base. Blue Cross is the only one that does not seem to cover it for some reason, even though it's FDA approved since 1998. Now this is neurostimulation. I know you're all aware of this because this is the latest thing. Operation, it takes me probably about 3.5 hours to do this. You have to dissect out a submental incision, or actually a submandibular incision, find the anterior, which is the medial branch of the hypoglossal nerve, because that's the one that draws the tongue forward. And then you put the stimulation electrode on that, make a subclavicular incision to put in the battery pack. It's about the same size as a pacer, which would go on the left side, a cardiac pacer. So we put it on the right. And battery lasts about 10 or 11 years. And then the incision below the pectoralis between usually 6th and 7th rib, close to the pleura. That's the sensor. So it senses respiration. And then when the person is ready to breathe, it goes ahead and pulls the tongue forward. But you have to select out the patient for that. Otherwise, it doesn't work. So retrolingual exam, endoscope, you put it at the free end of the soft palate and grade the view of the larynx. So one of the hardest things I have to do in training residents is they want to get right up on top of the tongue base or the epiglottis or the larynx. And I like to stress, you need to get a global view. And then when you're looking at the retrolingual airway, are you able to see the full view of the larynx, the chords, the arytenoids, and so forth? Or is it a partial view of the chords? In our template, I say posterior chords only, or arytenoids only, or you just see the tip of the epiglottis here in this diagram, or you can't see anything. The tongue overrides the epiglottis. Which is something we saw this morning in a drug-induced sleep endoscopy. And then the character of the epiglottis. Is it leaning posteriorly? Is it floppy? Does it get sucked back into the larynx? Does it fold from lateral to medial? Is it an omega epiglottis? And is the vallecula patent? Because sometimes just taking care of an obstructing lingual tonsil will help with the epiglottis. Sometimes you got to tie it back with an epiglotopexy. And so these are just different views to illustrate that. You get a full view of the larynx, and then small. This is my photos, but Tucker Woodson's paper to illustrate different obstructions. So this morning we saw obstruction on the lower right that was in a 15-year-old. So I got to think about what we're going to do with him because he has mild sleep apnea. And then out of Jonas Johnson's book, University of Pittsburgh, I thought this was great with a Mueller's maneuver, or you can even use it during DICE obstruction, drug-induced sleep endoscopy obstruction. So you have anterior to posterior obstruction. You have circumferential or lateral to medial. Lateral to medial is probably the hardest because you got to stretch out that pharynx. Works best with a maxillomandibular advancement. Hyoid suspension can help with that, and even a transpalatal advancement. Circumferential obstruction, that's usually in the palate, not so much retrolingual, and that's where I go with the lateral expansion pharyngoplasty. And AP obstruction in the palate, you need to think of transpalatal advancement, or in the hypopharynx, hyoid suspension would be helpful there. So talking about the Mueller's maneuver, again, it predicts if you see a significant lateral to medial collapse, then UPPP is not going to do very well. And if you see a retrolingual obstruction with the Mueller's maneuver, UPPP is not going to work. So it's basically a maneuver to predict failure of UPPP, and it focused treatment on the hypopharynx. Lateral pharyngeal wall collapse, we just talked about that, hyoid suspension, lateral expansion technique, transpalatal advancement, and maxillomandibular advancement, which oral surgeons do. So drug-induced sleep endoscopy is done in the OR with sedation. With adults, it's propofol. With kids, there's a little bit of dissension about what's the best. So on the left, this is the patient with bilobed linguals, awake, supine, and then you're going to see in a moment that on the right with sedation, he obstructs. So there's a difference in the awake versus supine airway. And this patient, I would consider a hyoid suspension, possibly a hyoid suspension with lingual tonsillectomy, which I think I have on the schedule for Thursday. Not this patient, but a similar one. Okay, and then functional obstruction. The lingual tonsils are so big that they're causing that epiglottis to collapse. Take care of the lingual tonsils, the epiglottis is not going to collapse posteriorly anymore. And then in the upper right, more with children, and Dr. Carl will talk to you about this, I'm sure. You'll have a retinoid obstruction where you can do a mucosal reduction there. And then the bottom, epiglottic obstruction. So this is just simply epiglottis by itself. And you know, it may be that the AE folds are a little bit shortened, but you might need to do an epiglottopexy to attack that back and stabilize it a little bit. So when do we use drug-induced sleep endoscopy? It's best when the site of obstruction is unclear, like that 15-year-old I had this morning, or that first patient I had 12 years ago, or they've had surgery and they're coming in and the results are less than optimal, and you're not quite sure where the next step is. And, or you can do for any patient who's a candidate for surgery, or anyone who's a candidate for an oral appliance. And the advantage is you have a dynamic assessment of sleep obstruction, because the muscle relaxation is not the same. And again, there's no muscle tone during REM sleep, which is oftentimes a worse obstruction. And it's artificial sleep, but you do get stage 1, 2, and 3. You don't get REM sleep with propofol. And then as far as sites of obstruction, I thought this was a great paper from the clinics 17 years ago, where it looked at sites of obstruction. You can see it in the right box that 12.5% of patients had 6 separate sites of obstruction, where maybe 14% had 1 site. And treating one site of obstruction sometimes alleviates the other sites, but that's really hard to predict. Although there was a paper out of China probably about 10 years ago where during sleep endoscopy and multi-level obstruction, they put a nasal airway in to eliminate palatal obstruction in order to see if the base of tongue obstruction would resolve in order to guide your surgery. I've tried this on a number of occasions, and it's not as easy maybe as it sounds. So key points to guide surgical treatment: identify the site of obstruction and the structures involved, and then again the pattern of airway change: anterior, posterior, lateral, medial, circumferential, because you use these things to formulate a surgical plan. We've talked about this. And then the vote classification, what Eric Kazarian came up with about 10 years ago. I personally have not used this. I've written up my own template because this came out about when I was making my own template. I tried to use it for a while, and it wasn't working for me the way I like to work, but we're talking about maybe introducing it again. And you're looking at the three types of collapse on the right, the configuration as he puts it. And the blacked out boxes means you can't have a concentric collapse of epiglottis, for instance, or a lateral collapse of the tongue base. And then degree of obstruction, none, partial, or complete are the three choices you have. And then oral appliances or oral appliance therapy. There's an anatomic basis for why this works. Cephalometrics has shown why it works, CT scan, MRI, awake supine endoscopy, and even sleep endoscopy. So what it does, increases the oropharyngeal diameter, decreases collapsibility by putting a stretch on the lateral pharyngeal walls, opens both the retrolingual and retropalatal airways. Not everybody, and so that's why you check ahead of time, because sometimes just opens the tongue base but not the palate. And it treats, in the patients for whom it works, it treats both the retropalatal and retrolingual obstruction. So during sleep endoscopy, have the anesthesiologist just pull the jaw forward about 5 millimeters, and you'll see how much improvement you get. And I also look to see if it improves the palate at the same time, because if it only improves the tongue base, then oral appliance is probably not going to be very successful. And this is a jaw thrust, which will anticipate, and then the palate it opens to, anticipate how an oral appliance might work. I think that's remarkable. It's fun too. And then again, another patient with jaw thrust, doesn't have much retrolingual airway, and we're going to give him a little bit of advancement. It's also called the S-mark maneuver, E-S-M-A-C-H, M-A-R-C-H. So it opens the palate and the retrolingual airway. And then we release it, and the palate obstructs again. So successful by endoscopy in probably close to 80%. And this is a patient I had. An attorney from the southern part of West Virginia came up. So we looked at his sleep endoscopy without an oral appliance. He actually had a TAP appliance that we put in during the procedure. We just lightened his anesthesia up a little bit, had him put it in, and then we looked again. So that was without the oral appliance. Now we put 7 turns in it, and you can see that he's no longer obstructing palate and tongue base. Tongue base still quite small. We eventually opened it up to full bore. This just shows how he was adjusting it intraoperatively. So basically what we did is during the sleep endoscopy, we titrated the oral appliance to prevent obstruction. Those are his hands, okay, not mine. Okay, fully open. Beautiful, huh? Very impressive. Okay, and with a CT scan, mandible in normal position in the OSA patient in the above 4 frames, and you can see during breathing, airway goes away, but with an oral appliance, mandibular advancement device on the bottom 4 frames, the airway stays open during sleep. So this is a slide I took from Peter Sistuli. He's an Australian, that illustrates that there's an equivalence in effectiveness. You have a high efficacy with CPAP, but modest compliance, and opposite, you have a modest efficacy with the oral appliance, but high compliance. Modest efficacy, that means it's FDA approved only for mild to moderate sleep apnea, and you got to choose the patient in whom it's going to work. So positional therapy, in the US, I've prescribed the Zoma positioning pillow, keeping the person off their back. The slide on the right is from Europe. This can work in patients who have positional OSA, and that's why you like to look at position if you can find it in the interpretation of your sleep study, because they could have maybe an AHI of 30 on their back, maybe 20 overall, and then on their side, it's maybe 5. So this would be ideal for them. Then they don't need CPAP or an oral appliance. So it's positional about 50 or 60%, but that doesn't mean you can use the positional therapy in 50 or 60%. But those you can use it in, it's equivalent to CPAP. And they actually, they sleep better too. The total sleep time is unchanged with the positional device and the bottom line there, but it's decreased with CPAP. CPAP interrupts sleep. So the conclusion on this area is that it's equivalent to CPAP in normalizing AHI in patients who have positional OSA, and they get similar effects on sleep quality and nocturnal oxygenation. What about bariatric surgery and positional therapy? Well, most of these overweight people don't have positional OSA, but after bariatric surgery, the non-positional becomes less severe with a lateral position. So conclusion, if OSA is an upper airway disease, and it is, then the airway needs to be examined or evaluated. And if this is true, then any of these procedures, tracheostomy, CPAP, upper airway surgery, should improve OSA, and they do. So we identify the abnormalities and the sites of obstruction, pattern of obstruction, and understanding most have a multi-level obstruction, and we put together a treatment plan. I hope you all get this when your board comes around. And this will conclude today's lecture.